So I will describe to you now some basic process and methodologies for the de-identification or anonymization of clinical trial data. Just in the way of background, talk a little bit about privacy analytics, that we develop data anonymization solutions. We're a spin-off from the University of Ottawa. And we do a lot of work on clinical trial data, on clinical study reports, and structured data, IPD, to allow the sharing of that data publicly and with regulators such as European Medicines Agency and soon Health Canada, where both have policies and regulations for making clinical study reports publicly available. And then also working with industry and academic medical centers to allow them to share their structured individual level patient data. So we've worked on hundreds of CSRs and hundreds of trial data sets, and we follow the methodology that I'm going to describe to you now. It's a commonly used methodology, and I'll maybe give you also a little bit of history on how it works and where it came from. So the first concept around de-identification is the concept of the spectrum of identifiability. So if you can think of the identifiability of patients as falling on a spectrum between identifiable to fully de-identified or fully anonymous, then you can sketch out regions on this spectrum. So you have identified data, the first part, and as you move along the spectrum, you have this concept of pseudonymous data. I'll define pseudonymous data momentarily, but it's essentially where you remove the direct identifiers. So in the context of clinical trial, it's either removal or encryption of the subject IDs. And then you have this concept of strongly pseudonymous data further down the spectrum. And this is pseudonymous data with additional security and privacy controls put in place. One key thing here is that pseudonymous data is still considered personal information, and this is the case in most jurisdictions around the world. I think all jurisdictions around the world really treat pseudonymous data as personal information, but it's not a controversial issue, and therefore coded data or masked data or single-coded, double-coded, blind-coded, all of these are considered personally identifying information. They're different variants of pseudonymous data. Then you have this concept of a threshold on this spectrum, and the threshold would essentially be a probability. So once the probability of identification crosses that threshold, then you have anonymous or de-identified data. So the objective of de-identification really is to be able to transform the data or modify the data and the context in such a manner that you can claim that the risk of re-identification or the probability of re-identification is below that threshold. And then you can keep anonymizing the data further to reduce the risk, but once it crosses the threshold, it at least meets the legal requirement to be able to say that it is de-identified data. And as a practical matter, for all the evidence that we have today, that if you use strong methodologies, that the likelihood of successful re-identification can be very small. So a key concept here is that the risk of re-identification is not going to be zero. It's going to be below the threshold. You want to choose the threshold to be low, to be a very low threshold, but the risk at the end of the day is not going to be zero. The only way to get zero risk of re-identification is not to share any data, because there's always some risk. So the objective really is to ensure that the risk is low enough, or is below the threshold, and to be able to demonstrate that in a defensible manner. So some more concepts, basic concepts around the identification. So you have direct and quasi-identifiers in a data set. So this applies to health data in general. In practice, for clinical trial data, it's mostly subject IDs that are the types of direct identifiers that exist in the data. And we're focused here or now on patient information, not investigator information, because in clinical study reports you have information about investigators and site staff as well. So I'm really just focusing on patients. So for patients, you have direct identifiers. that are the subject ID, and then for quasi-identifiers, you have other types of information such as sex, date of birth, date of death, any kind of demographics or socioeconomic status information, as well as dates and then rare events and procedures and diagnoses. And quasi-identifiers are important because most known re-identification attacks were done on quasi-identifiers. So really, you want to take care of this two type of information in a clinical trial data set. If you deal only with the direct identifiers, then you have pseudonymous data. So the definition of pseudonymous data is you encrypt the subject ID or remove it even, but you maintain all the quasi-identifiers. If you deal with all the quasi-identifiers by generalizing them, suppressing them, adding noise, there are many different techniques, then you can reduce the risk sufficiently on the quasi-identifiers to get anonymous or de-identified data. So let's talk about de-identification standards. I like to start off with HIPAA because the HIPAA privacy rule in the US has the most prescriptive set of de-identification standards of any regulation. And it's been around also longer. So you have two standards: safe harbor, which essentially lists 18 data elements that if you remove them, the data is considered de-identified. And safe harbor is a very simple cookie cutter type of de-identification standard. My general recommendation is not to use safe harbor because clinical trial data are very complex, and safe harbor ignores a lot of the complexity of that data. So it results in a lot of very sensitive and very detailed information about the patients not being considered at all during the identification. So you can create data sets that meet the safe harbor standard and still have a high risk of re-identification. So you can still have safe harbor data sets where the probability is above the threshold, basically. There are some limited cases where safe harbor can be suitable, but these cases are not clinical trial data. If you're covered by HIPAA, you can check the box and apply safe harbor. But from a risk management perspective, it doesn't necessarily protect. It's not necessarily protective. And then outside the U.S. or if even in the U.S., if you're not covered by HIPAA, then this would not be a good standard to use. Expert determination is the second standard under the HIPAA regulations, and essentially a statistical approach to de-identification. And so that's the one that I will talk about now. I also want to mention in Europe under the GDPR, the Article 29 Working Party published an opinion in 2014, which has been interpreted by various regulators, including CNIL, the French Data Protection Authority, as to say that the anonymization, an acceptable anonymization process for the regulatory and supervisory authorities in Europe consists of one of two options. One is if you have create a data set that has none of the following properties: singling out, linkability, and inference, or you do a risk analysis. For clinical trial data, it's very difficult to meet the three criteria: singling out, linkability, inferences. Those three, and we've written an article summarizing why. But just for now, say it's very difficult to meet those criteria and have useful data for clinical trial data. Therefore, the practical approach is to really do a risk analysis or follow a risk-based approach. So all that to say is that regulators in Europe will publish an opinion on anonymization, as well as under the US HIPAA expert determination standard, statistical disclosure control methods or risk-based approaches would be deemed as acceptable ways to de-identify data. This is really important because clinical trial data will often come from patients located or situated in multiple jurisdictions. You'll have the US, you'll have Canada, you'll have Europe, you'll have Japan, you'll have Korea, and so on. So you will need to ensure that your data identification strategy or approach would be accepted in all of these jurisdictions. So here I've given two examples, Europe and the US, where a risk-based approach is deemed to be acceptable. There are many standards and guidelines that have been published around risk-based de-identification from different countries by different types of organizations, varying from regulators to professional associations, academic institutions, the Council of Canadian Academies, the Institute of Medicine in the US, and so on. So you have various organizations that have published guidelines for risk-based de-identification. Some of them are specific to clinical trial data. Some of them are health data in general, pertain to health data in general, and some of them are more generic and don't apply to health data. They're to any type of data. All that to say is that risk-based approaches are not controversial and they're consistent with existing standards and guidelines. The European Medicines Agency Policy 70 guidelines for the de-identification of clinical trial data does recommend a risk-based approach to anonymization, and Health Canada has published their final guidelines, which also describes a risk-based approach to de-identification. And this is for clinical trial data, for Health Canada's regulation on clinical trial data sharing. So let me talk a little bit about the process. First of all, you have to set a threshold of what's acceptable risk. Then you measure the risk compared to the threshold. And if it's below the threshold, you're good. It's deemed to be de-identified. And if the risk is above the threshold, then you have to apply various transformations to bring down the measured risk to be below the threshold. So that's the basic process. It's relatively straightforward. Some key things here, though, is that you have to be able to set a threshold, set a quantitative threshold, and you have to be able to measure the risk to compare it to this quantitative threshold. Another key consideration then in risk-based anonymization is the overall risk. This probability that we measure consists of two things. One is your data risk and one is your context risk. The data risk is the risk probability of the data being re-identified once an adversary has access to the data. And then the context is the security and privacy controls and contractual controls that are in place to protect the data. So the data risk is contingent on the context. So this is essentially a conditional probability that the data risk is contingent on various controls, security controls, privacy controls, and contractual controls that are in place. And the overall risk is a product of those two types of risks. For public data, there's no context risks. There are no security, privacy, and contractual controls in place. And therefore, for public data, it's only data risk. But for non-public data, such as the type of data shared through various initiatives, such as clinicalstudydatarequest.com, such as Vivli, such as Yoda, in those cases, there are security and privacy controls that are put in place, and therefore you have a context risk to take into account when you're de-identifying the data. So really, then, how you share the data plays an important role in the de-identification process, because that determines the context. You have public data, which is shared with limited or no controls in place, and then you have data shared through portals. So the clinical study reports shared by the EMA and Health Canada are, for practical purposes, considered public data. So you really look at the data risk only, and then the structured data, the individual level patient data that's shared through these platforms is typically provided through secure environments, and in that case, you have to take into account the context when you're evaluating the risk of re-identification. So let me just dig one more level deeper, just one more layer of the onion. I'll peel that off just to give you an idea about measuring risk. So here's an example of a data set with direct identifiers, quasi-identifiers, and other variables that we're not going to worry about. So there are no names and telephone numbers in clinical trials, so those are out. The IDs, which are typically subject IDs, would be encrypted. And then you measure the risk on the quasi-identifiers. So in this example, you have 3 males born in 1959, and therefore you have a group size of 3. And the risk is really measured on the group size. So it's 1/3. The third is the probability assigned to each one of these individuals. So really data risk is a function of the group sizes. It's more complicated than that because you measure the group sizes on the populations, not on the actual data, clinical trial data set. So you have to estimate the group sizes in the population, and then there's different ways. There are different ways to define the population. So it's an estimation problem. There are various statistical models that have been developed to estimate group sizes and populations. And the second complexity factor is longitudinal data. Clinical trial data is longitudinal. So how do you measure group sizes for longitudinal data? So there are multiple issues that have to be considered, but the basic idea at the end of the day is you're trying to estimate group sizes, and the probability of re-identification, the data risk, is a function of these group sizes. In terms of the context, as I mentioned, the context has, you look at the security controls, privacy controls, contractual controls, motives and capacity. So there are various checklists and models that have been developed to quantify this context and convert it into a subjective probability that works very well in practice and that can be included in the overall risk modeling exercise. So all to say is that the models have been built, they have been documented, they have been published to evaluate the data risk, to evaluate the context risk, to combine them together to come up with an overall estimate of re-identification risk for clinical trial data. And the examples I mentioned earlier of guidelines, etc., describe a lot of that process. The last thing I will mention here in terms of methodology is what's an acceptable threshold. So there are a lot of precedents for what's an acceptable threshold, and these precedents are global, varying from the CDC to NHS Scotland to Centers for Medicare and Medicaid, and so on. But they vary from 0.5 to 0.05. These are the typical probabilities. Many organizations tend to copy each other, so the range has remained relatively stable over time. The Centers for Medicare and Medicaid uses 0.09 for the release of very large data sets, and the EMA is also using 0.09 as a threshold for their data sharing initiatives, and Health Canada is also using 0.09 as the recommended value for their de-identification. So 0.09 seems to be a commonly used value today as a threshold for de-identifying data. And there are very strong precedents for that value. It's more on the conservative side compared to values that have been used in practice, but you can choose lower values if you want to be more conservative, or you can choose higher values if you want to deviate from what's emerging as a common threshold for clinical trial data. But in any case, there are a lot of precedents here going back many years by a lot of very reputable organizations that have been sharing large amounts of data for quite some time. So basically, the idea then of risk-based de-identification or risk-based anonymization is that you have multiple layers of protection. You have some initial risk. You put in place contractual controls to chip away at that risk. Then you have some residual risk. So you implement some security and privacy controls to chip away at that risk. Then you have some residual risk, and you use that residual risk you control that residual risk by perturbing or modifying the data. So the more controls you have, the less you need to perturb the data, and this is why these secure computing environments for sharing data are attractive, because you have strong contractual security and privacy controls, and therefore you get richer and higher quality data to work with within that environment, but still be able to make a credible claim to regulators and to patients that the privacy of their data is being protected. So I'll close by saying that the whole issue about protecting privacy and anonymizing data, although it does raise a lot of concern, there are some good methodologies that have been developed, that have been in use in many years. There are many guidelines. It's well documented. The practices are quite robust. They have, I think, strong empirical validity. There are known re-identification attacks on this type of data, and even on clinical trial data, that have not produced any meaningful successes. Therefore, based on all the data and the evidence we have today, that these types of methodologies are robust, they work well, and therefore one should not fear or worry or use the privacy issue as a reason not to share data, because this is a solved problem, and there are good ways to execute in this and provide robust and defensible protections.